think we go to the next talk by Dr. Gopal Pillai. Let me just open what's the talk.
Thank you very much, ma'am. I'm sorry for the intrusion. My own IC is happening on another place. That is why I'm very sorry. So I'm talking today about giant retinal tears. So what is so giant about the giant retinal tears? Full thickness circumferential tears more than 3 clock hours often are associated with vitreous detachment. That is usually what is said, giant retinal tear. More than 3 clock hours is about 90 degrees. So etiology wise, idiopathic is very common, more than 50%. Trauma, high myopia, aphakics and pseudophakics. And there will be certain people with predilection genetically, like Marfan's and Sticklers, etc. Demographically, it occurs only about 1 to 2% of the total retinal detachment. Average age is about the fourth decade, and males are more than females. And 13% of the GRTs are bilateral, and 50% risk of a contralateral retinal detachment if there is GRT in the other eye. So we have to differentiate a giant retinal dialysis from the giant retinal tear. In a giant retinal dialysis, there will be a vitreous remains adherent to the posterior aspect of the tear. So retina is not very mobile. Unlike that, in a giant retinal tear, what happens is the vitreous, the PVD is occurring at that point, and so the retina starts crumpling, and there's a total mobility, and that leads to huge PVR. And so rolling on itself and then crumpling up into a PVR is very common in giant retinal tear if it is not treated earlier enough. So the management is challenging because of the PVR changes to the extreme peripheral nature of the large tear which is there. So if you have to remove the vitreous at that particular area, sometimes you may have to remove the lens as well. Epiretinal membranes between the inverted retinal flap makes unfolding very difficult. And sometimes the radial ribs may be present, which whenever we are doing a air fluid exchange or a PFCL, they may rip off also. There is a higher chance of slippage because there is a large area of a tear and it may completely slip down if it is not supported well enough. So we have to choose between lens sparing surgery, which we used to do quite a number of times before. But once the wide angle has come in, and the visualization is much better, now generally lens sparing vitrectomy is much less done. So management options initially, I mean, this is historically a great management option. Like the patient is lying prone and somebody is doing it from below upwards. So that is all gone now. Introduction of MIVS with PFCL is one of what is usually done. Sometimes I use air, sometimes I use PFCL. It depends upon the amount of PVR, etc. Increased primary attachment rates is very high. Actually, 58 to 94% is in the literature. But I think all of us would have a very good primary attachment rate. But sometimes post SOR, the chances of redetachment are also a little higher in GRTs. So the first thing in this thing would be to find out whether lens sparing PPV versus lensectomy PPV. In an extremely peripheral place where there is a lot of PVR and membrane peeling needs to be done in the extreme periphery, then we may have to require to remove the lens. And usually a lensectomy is not what is preferred. Probably you would do a phacoemulsification now and then go there. And PPV with or without buckling, generally buckle is now avoided because it would not help a lot in slippage also. And with the wide angle visualization systems, we can see up till the periphery and do it. And so buckle is not generally preferred. I think there can be a difference in opinion in the panel as well. The main focus points would be that the flap edge needs to be supported by appropriate retinopexy, be it cryo, be it laser, anything like that. And removal of the periretinal membranes, which avoids the repositioning of the flap. And if there is a PVR, then we may require to do retinotomies and retinectomies to if there is shortening. And the extreme peripheral bit of the giant retinal tear, that flap of the retina, needs to be cut off to prevent further problems. So I told about the buckling. Dialysis in early cases, flap is not inverted, PVR up to grade B, clear lens. Then that in a giant retinal dialysis, we can still do just a scleral buckling and get out of it, especially because most of these would be young people, myopes, etc. So buckling can avoid a lot of other intraocular issues. But isolated buckling procedures are now lesser and lesser performed, especially in giant retinal tears. It's directly we will go into an MIVS, and most cases can be used as an adjunct. PFCL can be used as an adjunct. So lens trauma, self-sealing, reduce surgical time and complication, that's the MIVS advantages. And problems associated with the slower removal of the vitreous and difficulty to reach the flap and aura. So lens can touch, and at that point of time, we may have to convert to a lensectomy or lens removal. Prolonged time for air fluid exchange, to prevent slippage and need extra caution. And if you're using a PFCL, always make sure that it doesn't have any subretinal migration of PFCL. So in phakic patient, it is sometimes difficult to shave the vitreous up to the base and remove the flap, but then you can indent with one hand, you use a chandelier, indent with one hand, the other hand you can do that. And laser also, sometimes it is difficult, but you can indent with one hand and use laser. So that's a surgeon's decision. Encircling band can be applied before PPV. Again, I'm not a big fan of that because it doesn't prevent slippage. PFCL is the third hand, which helps flatten and hold it in position while you do the peripheral vitrectomy. The retina will be very stable, and also it helps us if you completely fill the eye with PFCL, it avoids slippage, etc. Chandelier illumination is required now because we will require 3 ports, because we will require direct PFCL silicone oil exchange also. So these are some of the surgical steps. We'll go to the surgery. All the anterior retinal flap and vitreous up to the vitreous base needs to be removed. If left, increased chance of proliferation and PVR. Laser, I put 4 or 5 layers of laser all around 360 degrees, and maybe cryo to the anterior part of the flap as well. So that is a typical case. Pre-operatively and post-operatively, you can see the laser marks as well. Air fluid exchange, it's imperative to remove all the fluid up to the PFCL edge to avoid slippage, and PFCL will be expanded with non-expanded consonant gas. But I generally tend to exchange PFCL with silicone oil. Silicone oil is what I usually do. Other eye, about 13% chances of GRT is there, and 40% risk of retinal detachment is there. Any lesion in any retinal detachment we will treat. Here also we will definitely treat. Prophylactic barrage. Prophylactic buckling, which was earlier advocated, is a little bit of a controversy. So now we'll go to a small video, about a 1-minute video of giant retinal tear. So this is it. So here we are doing, you can see that it is a fairly early giant retinal tear. Here you are removing the vitreous, and you can see the area of the tear there. That is the area of the tear. It's slightly inverted, but not so much PVR. So this is a case which can be amenable to just air fluid exchange also. So we will try that out first. After the vitrectomy is over, I did a retinotomy and tried it. But in the periphery, it was not completely flattening, so that I have to use PFCL now. Now I'm filling PFCL right till the. So when I'm using PFCL, generally I'll tend to use a 4th port, because because of the valved cannulas, it's extremely difficult for something to be injected without a vent. So you require automatically a 4th port. This is indentation, and you can do vitrectomy also indented, and you can also do laser indented there, so that you completely do that. Now this is direct PFCL silicone oil exchange. You can see that the silicone tip is on the left hand, and it is sucking this PFCL out. And once it is sucked a little bit, then we will inject silicone oil with the other hand. That is how you fill and finish PFCL silicone oil exchange. Thank you very much.
A nice presentation, Dr. Gopal. I have a very little question. Pre-operatively, you diagnose a patient with giant retinal tear, but while you are starting the case, just then you have realized it is not giant retinal tear, it is giant dialysis. Will it change your mode of treatment? Would you go for the scleral buckle rather than doing vitrectomy, or you will stick to your vitrectomy?
When did we understand that it is a giant retinal dialysis?
On table.
On table. Which means the preoperative evaluation was not proper.
It was not proper means the picture was such, you thought just a glimpse look that it is a giant retinal tear, but actually it is a giant retinal dialysis. So will it change your mode of treatment or not?
Once you are entered inside the eye, generally then I may not change the mode of treatment unless the patient is very high myope, a child, a young person in which it is extremely difficult to remove the vitreous right till even beyond the aura. In such a case, because you need to remove the vitreous right till, if it is a dialysis, we need to remove the vitreous right till the aura, which may not be possible in that. So I may, if I go inside, I may do it, but I may supplement it with the buckle.
Okay, thank you.
See, if there is a giant dialysis, the problems would be the same. So why would the treatment be very different?
If there is no eversion of the fluid flap, you can go with the scleral buckle also.
Yeah, okay. Thank you. Thank you, Dr. Pillai. Good videos. Yeah.
Thank you.